Welcome to A&P Live Studio. I'm your host. As a registered nurse and an anatomy and physiology instructor for advanced healthcare professionals, I'll be your guide through our session today. Our goal today is to really build a clear, step-by-step understanding of pituitary adenomas. We're going to connect the gland's normal function to exactly what happens when things go wrong and how that dysfunction shows up right there in the clinic. So, to guide us, let's start with a clinical scenario. I'd like you to meet Maria. She's 46 and she's come into the clinic with a 9-month history of these persistent headaches and some blurred vision. She's also noticed she's gained a significant amount of weight and has these new kind of purplish stretch marks on her abdomen. Maria's story is going to be our clinical anchor as we explore the mechanisms behind her symptoms. Here's our roadmap for today. We'll kick things off with the normal structure and function of the pituitary. From there, we'll get into the core pathophysiology of these tumors. Then, we'll tie that directly to the clinical picture, review how we diagnose and treat them, and wrap up by looking at the systemic impact. So, let's get started. Before we can really grasp what goes wrong, we first need a rock-solid foundation in normal pituitary physiology. Understanding this master gland is absolutely the key to understanding the disease. So, the pituitary gland. It's this tiny pea-sized organ, but wow, does it pack a punch. It's nestled very securely in a little bony cavity at the base of the brain called the sella turcica. And what's so important to remember is that it's actually two distinct lobes with different origins. The anterior lobe, or adenohypophyseal, actually grows up from the roof of the mouth during development, while the posterior lobe, the neurohypophyseal, is really a downward extension of the brain itself. And this dual origin is crucial for their totally different functions. Now, this table might look a little dense, but what's really crucial to grasp here is just how elegantly the anterior pituitary is organized. Think of it like a family tree. Its cells develop into 3 major lineages, and each one is driven by a master transcription factor. The PIT1 lineage gives us the cells making GH, prolactin, and TSH. The TPIT lineage produces corticotrophs for ACTH, and the SF1 lineage, that governs the gonadotrophs making LH and FSH. This isn't just academic trivia. This lineage system is now fundamental to how we classify and diagnose these tumors. Okay, so if these cells are so highly regulated, how do things go wrong and form a tumor? Let's move on to the pathophysiology to find out. Pituitary tumors, which we now more accurately call pituitary neuroendocrine tumors, or PITNETs, are actually surprisingly common. If you look at autopsy and radiological studies, they suggest that about 10% of the general population has one. But, and this is a big but, the vast majority are benign and clinically silent. In fact, it's estimated that fewer than 1 in 1,000 actually cause significant disease. So the real question is, what makes that small fraction become a problem? Well, a key factor in whether a tumor causes trouble is its size. We classify them as microadenomas if they're less than a centimeter, and macroadenomas if they're a centimeter or larger. Now, microadenomas can still cause issues if they're secreting hormones, but it's really the macroadenomas that are more likely to cause symptoms, just because of their physical size alone. When these tumors do cause disease, they do it in 2 fundamental ways. First is through mass effect. That's where the physical bulk of the tumor just presses on everything around it. And second is through hormonal imbalance, which can be either too much hormone from a functioning tumor or not enough hormone because the tumor is squishing the normal gland. This analogy here just perfectly illustrates mass effect. Think about a tree root growing under a sidewalk. That relentless pressure eventually cracks the concrete. A macroadenoma does the same thing. When it pushes up on the optic chiasm above it, it causes that classic visual field defects called bitemporal hemianopsia, basically a loss of peripheral vision. This pressure is also what explains those persistent headaches that patients like Maria experience from the stretching of the dura mater. Now, a very specific type of mass effect is called the stalk effect. Remember, the pituitary is connected to the hypothalamus by a stalk. Normally, dopamine travels down this stalk to keep prolactin secretion in check. But if any tumor, even one that isn't secreting anything, compresses that stalk, it blocks the flow of dopamine. The result? The brakes are off and you get a mild to moderate rise in prolactin levels. So what's happening at the molecular level to trigger all this? Often, it's specific mutations. Somatic mutations, the ones we acquire during life, are the most common. For example, gain-of-function mutations in a gene called GNAS are found in many GH-secreting tumors. And similarly, mutations in USP8 are common in the ACTH-secreting tumors that cause Cushing's disease. In a smaller number of cases, maybe about 5%, these tumors come from inherited germline mutations linked to syndromes like MN1. Okay, so let's connect all this pathophysiology back to the signs and symptoms we see in patients like Maria. How does all this cellular and molecular disruption actually show up in a person? Tumors that are actively pumping out hormones lead to really distinct clinical syndromes. The most common are prolactinomas, which cause reproductive issues. Then you have GH-secreting tumors causing acromegaly in adults with that characteristic overgrowth of bone and soft tissue. And finally, ACTH-secreting tumors cause Cushing's disease. Now, if we look back at Maria's symptoms, that central weight gain and especially those purplish abdominal stria, they are textbook signs that point strongly towards Cushing's disease, all driven by excess ACTH. But on the flip side, macroadenomas can also cause hormone deficiency or hypopituitaryism, just by squishing the healthy parts of the gland. This loss of function tends to happen in a pretty predictable sequence. The cells making growth hormone are usually the most sensitive to pressure, so they go first, then the gonadotrophs, then the thyrotropes. The corticotrophs that make ACTH are the toughest, so they're usually the last to fail. And knowing this sequence is vital, because losing ACTH is a life-threatening emergency. So we have a patient, we suspect a tumor. How do we actually confirm the diagnosis, and what are the mechanisms behind our treatments? The diagnostic process is really a three-step approach. First, we run biochemical tests on blood and urine to directly measure hormone levels and confirm if they're too high or too low. For Maria, we'd be checking for high cortisol. Second, an MRI with contrast is the absolute gold standard for imaging. It lets us see the tumor's size, its exact location, and whether it's pressing on that optic chiasm. And finally, we do formal visual field testing to map out any deficits objectively. Treatment really has to be tailored to the tumor type and what it's doing. For prolactinomas, for example, medical therapy with dopamine agonists is often the first choice because they actually shrink the tumor and shut down hormone production. But for most other symptomatic tumors, including Maria's Cushing's, the frontline treatment is transsphenoidal surgery, where a surgeon goes in and physically removes the tumor to relieve the pressure and normalize hormones. Radiotherapy is usually reserved as a backup plan to stop the growth of tumors that can't be completely removed with surgery. All right, let's wrap this up by summarizing these concepts and looking at the broader systemic impact. After all, it's called the master gland for a reason. A dysfunctional pituitary has these huge, far-reaching effects all across the body. The excess cortisol in Cushing's disease, for example, is really tough on the cardiovascular system, increasing the risk for hypertension. The skeletal system can get hit hard in acromegaly or from deficiencies leading to osteoporosis. The reproductive system is obviously impacted by changes in prolactin and gonadotropins, and of course, the nervous system is directly affected by the mass effect of the tumor itself. So, to connect all the dots, we start with this precisely regulated gland. Then, a benign tumor, often from just a single mutated cell, disrupts that regulation through its size and its hormonal activity. This shows up as a very clear clinical syndrome, which we then diagnose and treat by targeting the tumor. But this leaves us with a really fascinating question. Given how common they are, why do the vast majority of these tumors stay benign? The answer seems to be in protective mechanisms, like cellular senescence, where the cells basically enter a state of permanent retirement, putting a powerful brake on them ever becoming malignant. And that brings us to the end of our session. Stay patho-curious, and I'll see you in the next episode. This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.